Hello and welcome to another episode of Onc Now, our oncology podcast. I'm your host, Dr. Jonathan Sackier, and I'm delighted to introduce today's guest, Professor Sebastian Stintzing. The good professor is an established name in the field of oncology and serves as head of the Department of Medicine, Division of Hematology, Oncology and Cancer Immunology at Charité Universitätsmedizin in Berlin. With a special focus on gastrointestinal oncology, particularly metastatic colorectal cancer, Professor Stintzing leads groundbreaking research into clinical outcomes and biomarker-driven treatments. We're excited to dive into his work and insights today, so please welcome to the Onc Now Podcast, Professor Sebastian Stintzing. Over to the podcast. So, Professor Sebastian Stintzing, welcome to the podcast. Lovely to see you here.
Yeah, nice seeing you. Thank you for inviting me, and thanks for having me.
Yeah, you're very welcome. I'm intrigued by what's behind your head. It looks like either a piece of abstract art or taking your frustrations out on the whiteboard.
Well, it's neither. So basically, no, this is a painting of my daughter, actually. So when she was like 5.5 years old, she and a friend of her was just like, expressing themselves. So as an oncologist, it's always difficult to choose the right picture in your office because if it's too dark, if it's like black and white, sometimes there are, feelings that you do not want to emphasize in your office. And the same is like, if you have a beautiful sunset, at the end of the live discussion, it's not like ideal. So this is something that I find is, positive in somehow showing the complicated, maybe pathways we want to target in oncology also. So it's abstract, but it's basically because of the colorness, it's kind of a friendly abstract picture.
Well, I like the analogy that complicated pathways in oncology. I really like that.
Well, we all, when we were in our PhD times, we all had our posters put on the lab where, whatever pathway, MAP kinase pathway, simulation, ubiquitation, whatever, you could have it as complicated as you wanted to. So this kind of reminds me of those old days.
Yeah, believe you me, just the mention of it, I start to twitch uncontrollably, remembering revising for biochemistry exams as
Absolutely.
students. So, Sebastian, I come at this from a slightly different angle because by background, I'm a surgeon and I've looked after many patients with colorectal cancer. And your research has significantly advanced the understanding of metastatic colorectal cancer. What are the most impactful developments in gastrointestinal oncology that you've seen in recent years that stand out in your mind as being the most relevant?
Well, I think we really, what we saw during the last years is really that we do not have entities anymore. So, when I started oncology 10, 15 years ago, 15, 20 years ago, actually, you had like colorectal cancer, and this was one homogeneous kind of cancer, and you treated it according to your box, right? But what we really see is that we are now getting more and more precision oncology, or what we named precision oncology 5 years ago is standard of care nowadays. And I think this is really a movement that has opened up opportunities for our patients. Really new options with a less toxic, more efficacious treatment according to their molecular makeup of their tumors. And this really changed also the way we see the different cancer entities that we sum up under gastrointestinal cancer. So I think this is really something that changed because we had all those theories 15 years ago, and now we are really hands-on. We have our drugs that we can use to really treat patients differently. Another large movement, and I think we should not underemphasize this, is really the introduction of immune checkpoint inhibition. So far, unfortunately, it's just an immune checkpoint inhibition, but overall, really the path that we started to walk on that is called immune oncology. So for a small percentage fraction of our patients, we are really changing a former deadly disease towards a chronic, maybe curable disease. I mean, there's a lot of discussion about, can you achieve cure, yes or no? But at least, we see more and more long-term survivors. And this is mostly due to immune oncology. But also, of course, when we have more precise treatment options, and together with our colleagues, of course, also from surgery, but also radiation oncology, we are now really able to move more and more patients from the well, deadly disease, uncurable disease, not resectable disease, towards a treatment where we have at least a curative intent. And this really changed the way we treat our patients and also how we work together with all other disciplines that are involved in cancer treatment. So even though you started from a different angel as a surgeon, I think we nowadays really work very closely together and discuss patients at different stages. For example, when I think of colorectal cancer, you know, we in former days we really thought, well, liver resection, secondary resection for liver metastasis is the curative intent. Yes, it is curative, absolutely. But for like 50%, 60% of our patients, the tumor will recur at some point. Nevertheless, with the techniques that have been developed in surgery, nowadays those huge operations are really minor procedures nowadays. The patients are fit after 2 or 3 weeks, and then they really can enjoy maybe half a year, maybe 9 months of chemo-free or treatment-free interval, which is very beneficial when we think of quality of life. So I think many things have changed. It is a very interesting and very forward moving area in the field of medical oncology, and also the interdisciplinarity. I really enjoy is to discuss cases from all different kinds of angles of colleagues that are involved in the treatment.
Yeah. I agree with you. And, I remember when there was the introduction of preoperative radiotherapy for rectal cancer and how that fundamentally changed the dialogue between surgeons and radiation oncologists.
Yeah.
And that one was actually, and having really interesting discussions about, well, this patient also has diabetes, so probably has a microangiopathy. So I'm going to have to think in terms of my resection margins and the vascularity of the anastomosis. And you could be having these technical discussions with people for whom that wasn't their lexicon, while they're teaching me all about their lexicon. And the idea of seeing a cancer patient now and not doing it in the context of a multidisciplinary team is anathema, and appropriately so. So thank you for that. At the time that we're having this discussion in the United States, there's a seismic shift in the issue of funding research, and I'm not going to make any political observations other than that this is going to have consequences, no two ways about it. Mind you, with the overheads that institutions charge, I used to struggle to get funding because, my institution's charging 62% overhead. For every dollar I need to spend, I need to raise, nearly twice that. So funding is tough these days, yet you've had several investigator-initiated trials in colorectal cancer. And other than funding, actually, maybe you can address the funding challenges, but also talk to us about the key challenges when designing and running these trials. And maybe with the changes in America, research in Europe will be somewhat more appealing to third parties.
Well, I still can remember when I was in my PhD times in California. That funding in those days, even I mean that's now like 12 years ago. So even this was of course a big issue, and the overhead, was basically raised by the administration of our institution. Well, on an annual basis, I would almost say. And of course, in Germany, we are a little bit behind those numbers. It's maybe more like 40%. But however, you need more money nowadays because safety has become a more and more important issue. Even if you use already approved substances, already approved regimens, the safety issues have really been, well, the level of reporting has raised to a point where it's really getting difficult to get enough funding for trials and studies in in a size where you can make reasonable and meaningful statistical analysis. So how do we get funding? Well, of course, there are federal funding possibilities in Germany also, which used to be very difficult when it comes to clinical trials. They really were focused on preclinical lab work. Then they developed a little bit into translational analysis, and only since like 2 or 3 years we really have funding um, from the federal agencies in Germany, where we can start um, doing clinical trials. So the volume of those projects are now at a size that we can start this. And yes, I think we will have like 5 investigator-initiated trials where the sponsor is our university, so Charité, and we are basically the sponsor delegating person responsible for those trials. And I would say 50% comes from federal and national funding sources, and the other trials are done by pharmaceutical industry. So they give us the funding, and we are then conducting the trials. And then of course it's always difficult. You need to find a scientific question that is also in target and in strategy of the respective, well, oncological substance or of the respective pharmaceutical company that is then willing to spend for your clinical trial. And of course, this is the spending issue, and this really takes a lot of time, many talks, especially to the industry, and then it takes 2, maybe 3 or 4 years from the first idea to actually start the clinical trial. And this is not only a problem of academics, it's also a problem of industry. We have sometimes our partner in industry, they are changing on like a biannual schedule. So, you talk to him in depth over 1.5 years, and then, another person sits in front of you, have this function, and you start all over again. So this, of course, is a problem, but overall funding is still there. And I think with good ideas from both sides, scientifically and also interesting for the industry, we sometimes, for example, have in the pivotal phase 3 trials, not enough elderly patients. So let's focus on this. And we later will also talk about the younger patient group. The same, of course, is true for those younger patient population. So the fraction within the standard clinical trials is usually small, and there we really can see and we can think about questions we want to analyze in our own IITs. So this is about the funding. But of course, next to the funding, the ideal need to be clinical relevant, because usually we have, well, depending on the size of the trial, somewhere in between 50 to 120 centers, also sometimes in Austria and France, to really answer our questions. So you need a question that is clinical relevant, so that your study centers are willing to put patients on this trial. Then, of course, inclusion and exclusion criteria need to be as easy as possible. I think that's really relevant. You do not want to restrict your patient population. Um, Especially in the field I work, it's basically a real world patient population that we are looking for, right? And therefore, we really have to be very careful in what kind of inclusion and exclusion criteria we really want to put or in our protocol. And then, of course, this is something we have not talked about yet, the patients are important. So patient advocacies need to be included in the setup of the trial as early as possible. So if we have a question that is of interest also for the patients, that is looking in specific um, questions our patients have, this is really helping with recruitment. And of course, the shorter the recruitment period, the less expensive a trial is going to be. And so this is also quite important to include patient advocates as early as possible. So the moment you have the funding, the moment you're starting to really develop the whole protocol, the full protocol, then patient advocates should be included. And this is basically the problems we have or the key challenges we have when we design a clinical trial.
Yeah, I remember, Sebastian, going to an event up in Leeds University, excuse me, invited by a good friend of mine, Professor David Jane, who's been on this podcast with me. David's a colorectal surgeon, and it was basically a think tank, and I was astonished to see all the different stakeholders who were included in these discussions. And it went, first time I saw it, my first reaction was, damn, why didn't I think of that? What a great idea to actually speak to the people whose lives you're impacting with your clinical
Yeah.
research. So I'd like to dig into one aspect. Talk to us a little bit about translational biomarker programs and how they enhance the clinical outcomes that you aim to achieve.
Yeah, I think we always have to think about where we came from. So basically came from, we have the clinical questions, we're doing a clinical trial, and then we have the clinical outcome, which really raised the impact of our trials was going back to the, for example, archival tumor material to collect this, to also collect, of course, like imaging data, which is also very important. And this nowadays has really developed to also collect liquid samples, not only for liquid biopsy, which I think will really change the way we treat patients in the very near future, I would say. But this, of course, gives your trial more impact. And of course, after the trial is done, you will have to look for additional money because translational workup and the funding for the translational workup is sometimes quite difficult to get. On the other hand, if you have those material in storage and then you have annotated clinical data to this, of course, this biomaterial is getting very, very precious, and you can do all kinds of collaborations afterwards. So I think the translational biomarker programs have really increased the impact of the trials. And also, when we have clinical data that we do not understand, we basically can go back and can try to find a biological rationale why the one or the other patient population is not does not have the same efficacy or the same benefit from the substances used than other patients. And I think that's quite interesting to get a better understanding how we should use the drugs we have, what is the most sensitive patient dash tumor population that should be treated with either one or the other substance. And I think this is really impacting our clinical daily clinical life, to get more knowledge not only about like the makeup of the tumor, of the carcinogenesis that is behind it, but also to find the right patients for the right regimen and the right substance.
Right, right. Yeah, again, recalling through my professional career how things have changed in this area, and and the rate of change is changing. Tell us a little bit more about the role of primary tumor location in metastatic colorectal cancer and how your findings from the Crystal and FIRE3 trials have impacted treatment strategies for patients with RAS wild-type tumors.
Well, so no, I mean, RAS wild type metastatic colorectal cancer patients should be treated with anti-EGFR treatment. And of course, the problem of the EGFR antibodies, so the epithelial growth factor receptor antibodies, cetuximab and panitumumab, is a side effect that is described as acneiform rash or exanthema. And this is, of course, something the patient sees. That is something also the people see when you are treating a patient with those drugs. So, of course, you want to find a patient population that really benefits from this, from those drugs or from this treatment strategy. And first of all patients were treated. Then we restricted it to the molecular defined RAS wild type population. And then by really deciphering the different patient population, by really sorting them out, we saw from a historical background, it was always rectum and colon. And we also always saw, well, the rectum people are kind of doing better. And so we really thought, okay, maybe it's location. And so we were able to find out, together with our American colleagues, of course, that left-sided colorectal cancer is more sensitive to anti-EGFR treatment than right-sided colorectal cancer, even though they are RAS wild type. And I think this really changed the way we treat our patients. As a biomarker guy, I'm not really happy with left versus right colon. It's easy to access, of course, but I want to know the biological rationale. And there's a lot of theories out there. Some are more convincing than others, but up to date, nobody has really understood why a RAS wild-type tumor deriving from a right-sided colorectal cancer is different when it comes to anti-EGFR treatment from a left-sided tumor. So I think we still need to look at it. It may be connected with the methylation status. It may be also one cause may also be the microbiome, which is different from left versus right colons. But in the end, we are not really able to understand this. And of course, even if you have a left-sided colorectal cancer, RAS wild type, the response rate is not 100%, right? And you also find those tumors on the right side, located on the right side, that will respond to anti-EGFR treatment. So I think it really helped us to carve out patient population that most likely will respond to anti-EGFR treatment. And the ESMO guidelines are a little bit stricter. They really say you should treat those patients with anti-EGFR treatment in first line. The NCCN guidelines are a little bit, give you more choices, I would say, are not as restrictive. But of course, this is the patient population where we nowadays see median overall survival times of 40 months and beyond. And I think that's if you treat them with anti-EGFR treatment, and I think this is really progress we have seen. So yes, it's easy to assess. That's why everybody is using it, but I would like to understand the biological rationale behind it. So
right. Yeah. Again, remembering that we would see patients with right-sided tumors present later, of course, from a symptomatic perspective, and if not picked up by screening. But then, noticing they did seem to respond differently. They did behave differently. Why? And we'll get into personalized medicine in a bit, but I've got a question about the FIRE 4.5 study comparing the efficacy of folfoxiride. And I'm going to upfront apologize. I have a mental block with my ability to pronounce the MAB drugs. I don't know what it is. So anyway, folfoxiride plus cetuximab or bevacizumab. forgive my pronunciation, as first-line treatments for BRAF, mutant metastatic colorectal cancers. Can you tell us about the key findings regarding the potential benefits of combining those treatments and how those results influence future treatments strategies for patients with this
Yeah.
particular genetic mutation?
So basically, first of all, this was a phase 2 study designed to show difference, superiority of cetuximab plus FOLFOXIRI versus bevacizumab plus FOLFOXIRI in this BRAF V600E mutant patient population. We are talking about like 8% of the metastatic colorectal patients which have a BRAF V600E mutation. A BRAF V600E mutation is a sign of a very bad prognosis. It's the worst prognosis we have in metastatic colorectal cancer. And I just talked to you about the RAS wild type left-sided 40 months. We are now talking about 18 months, 1.5 years. Okay, totally different tumor, totally different biology behind it. And the Fire 4.5 study was the first data we got from first-line treatment of this patient population, randomized, prospectively randomized data. Even though it's just phase 2, we treated a little bit more, about 107, roughly 110 patients in this study. And in those times when we started, the recommendations coming from retrospective analysis of different trials was you should use the triplet FOLFOXIRI plus bevacizumab. And we said, okay, let's see whether there was not a lot of cetuximab data there. There was a small single-arm study, the Wolfie study, that showed it's possible to administer to the patient. The safety is fine, it's feasible. So we said, okay, let's see and pick the winner for whatever it is. And we did this. And as I said, it was a superiority design trying to show the superiority of the cetuximab arm over the bevacizumab. Quite unexpectedly, the overall response rate was better in the bevacizumab arm. It was a higher, significant higher response rate. And this also translated in a significant longer progression-free survival time for the bevacizumab treated patient. And also, when it comes to overall survival, even not there was no power to detect a significant difference anymore. There's a clear trend of a better overall survival for the bevacizumab treated population. So after this trial, it was very clear we do not want to treat those patients with cetuximab in first line. And I think this really influenced, this basically answered these questions one and for all. Of course, nowadays with the new data we have with cetuximab combined with a BRAF inhibitor, of course, then you need the cetuximab in combination with the BRAF inhibitor. And I think nowadays the next step is already made with the breakwater study that we have seen like 10 days, 14 days ago at ASCO GI this year, where FOLFOX plus encorafenib, the BRAF inhibitor, plus cetuximab was superior to the treatment with standard of care chemotherapy. So it is quite clear when we started this study in 2014, so 10 years ago, this was a different time. Nowadays, we combine chemo plus precision oncology to get better results. We are still awaiting the progression-free survival time from the breakwater study, probably going to be published or presented at ASCO this year. So we just have to wait several months. But yes, so basically what was clear, cetuximab alone should not be used on BRAF mutant cancer, full stop. I think that's clear after the Fire 4.5 study. And also, if you want to go with chemotherapy, and there are countries in this world where you do not have access and no reimbursement to the quite expensive target treatment options, I think for those countries we really were able to show, okay, FOLFOXIRI plus bevacizumab is approved in most countries. This is a way you should go if you do not have other options on hand.
Right. Thank you for that. So we shall look forward to ASCO with bated breath. So we've talked a lot about the effectively personalized medicine in oncology. How do you see the integration of genetic and molecular profiling transforming the treatment landscape for metastatic colorectal cancer in the next decade, notwithstanding there are access issues, as you've identified, in various countries, whether it's because of
Yeah.
lack of insurance or lack of drug approvals or whatever? Talk us through what the future.
Well, I cannot foresee the future, unfortunately. Otherwise, I would know, which shares I had to have to buy right now. But I think it's quite clear. Um, we have now evaluated in depth the first layer of genetics, right? We have found subpopulations of tumors that we can target with inhibitors, and I think this will also go on, especially the KRAS enigma, which is to be solved by the new and upcoming RAS inhibitors of the second or third generation, which are less toxic and which are now entering clinical trials. But as I said before, genetics is the first layer. I think we are now, the next step is to be done, which is epigenomics. So really seeing which kind of pathways are activated. We are probably going to be combine different inhibitors in a meaningful biological rational way, which we weren't able before because we didn't understand how do they interconnect, how do they communicate those different mutations we find. And I think here epigenomics will really help us. And nowadays, with the development we have seen with liquid biopsy, we will also able to track those kind of real time reaction of the tumor on our treatment. So we will start treatment, and like 2 or 3 weeks later, we will see in the blood, is this the right way to go, or are there preformed primary resistance to whatever we have started? And if they are not, over the time, we will also see the development of secondary resistant mechanisms, which we may be able to target early on. I think this is something that we will now evaluate in the next decade, probably. So, with the help of epigenomics, with the help of liquid biopsy, we will really enable us to treat our patients differently and probably more efficacious, especially when we think over the time, because we have quite a good and quite efficacious first line regimen in colorectal cancer. I mean, with the RAS wild type, we have like 74% of response rate. So three-fourths of the patients really respond. But the duration of response is quite limited. So we need those ideas. How can we treat secondary resistant mechanisms early on? This is will be one way to treat our patients, and then also the combination of precision and immune oncology. I think here, as I said before, in the GI cancers, we just have made the first step towards immunological treatments, which are the immune checkpoint inhibitors and combination of those. But I think this will go on. We are talking about cellular therapies, if it's T cell treatment, if it will be bispecific antibodies, really getting together tumor infiltrating lymphocytes, T cells, and the tumor cells. I think we will see a lot of development also there. And these both areas will develop over the time.
Mm. I think it's always good to take a moment to stand and look over our shoulder and see the phenomenal improvements you and your colleagues have made for people living with cancer during your professional and my professional lifetimes. And my guess is that with large data sets and artificial intelligence, generative AI, our ability to interpret the huge amount of data and to be far more predictive will help us maybe also in terms of running clinical trials and using avatar controls and so on and so forth. But there's one area that I'm still a little bit confused. Well, I'm confused about so many areas. It doesn't bear thinking about, Sebastian. But cases of colorectal cancer in younger adults are on the rise. What are the possible causes behind this trend? I've seen many different theories. What's your personal perspective, and what steps can we take to address what is an emerging public health challenge?
Yeah. Well, I think Dana Farber really has done a great job in setting up trials, setting up clinical real world data sets to get a deeper understanding what is happening. Because overall, the GI cancer is getting less and less frequent due to different changes in the food impact, and also, of course, due to screening programs. But on the other hand, we have a population, these are the patients younger than 50, where we see a rise of colorectal cancer, especially colorectal cancer, and we have not really understood this. And I think Dana Farber really showed there might be an association of the sugar intake. So since the end of World War II, sugar has become more and more available, cheaper, and especially with new sweeteners like fructose glucose combinations, we have more and more sugar intake into our system, and this may actually change the microbiome you have in your gut, and thereby this may increase an local inflammatory status, which in the end, over time, will get you to more cancer. I think food intake is one, and we know if we are healthy, we are not smoking, we are, not drinking too much alcohol, we will probably be able to reduce our risk of colorectal cancer. But one aspect that is a little bit that needs to be more explored, I think, is also the question about exercise. 20 years ago, 30 years ago, we were not sitting in front of a computer. And some of us, are sitting in front of the computer in the office, and then they go home and sit in front of the computer and, do some Instagramming, do some, creating some content, or maybe also playing with computer games. So I think this has changed a lot. The question is, do we have enough exercise in our daily life? And I'm not, I know, especially also when I think about the US, there's this well-educated people that are doing a lot of sports, that live healthy, that are getting older and older. But we should not forget those people that really have to work hard, long hours, are not able to get healthy food because it's cheaper to go to like a fast food restaurant, and maybe also do not exercise enough. So I think we really have to raise awareness in children during school to really get an understanding, how can I live a healthy and a long life. And I think food and exercise, these are two two keys to really live longer and healthy, and also to protect and to prevent GI cancers.
Yeah, absolutely. Well, totally in line with what I've been hearing and writing about and teaching. Colorectal Cancer Awareness Month just around the corner. What are some key actions people can take during this time to raise awareness about the importance of early screening and prevention, especially in at-risk communities? And, it seems it's always the case. There's the worried well who will have a colonoscopy as often as possible. And then there's the people who are highly at risk who will never have a colonoscopy. Sadly, I lost a very dear friend and colleague who was a surgical oncologist who never had a screening colonoscopy. And he died from colorectal cancer. So what can we do? What's your advice to the doctors and others listening in?
I think Colorectal Cancer Awareness Month is like the possibility we have to really put colorectal cancer on the agenda, on the public agenda, and also to advertise screening colonoscopy. So in Germany, it's way too complicated. The official material we get from our insurance companies are too complicated. Nobody really understands what do they want to tell me. I think we really have to break it down quite easy. And I think, for example, the Netherlands has done a really great job. It's basically like a comic, and you get it for free. You get your colorectal cancer blood test, your stool test in the mail, just automatically if you are at the age of risk, in the risk age. And then you can basically put it back by mail. Everything is paid, and then after 2 to 3 weeks, you get back an envelope which is either red, please go to and see your general practitioner, or it's green saying, all fine, see you in 5 years. So I think we really have to lower the accessibility of those actions. I find it quite interesting that it's also very cost effective for the insurance companies. So the Californian-based medical program, not Providence, it is. I don't. There is data really showing that it is cost effective for healthcare insurance.
For a country, actually,
Yeah,
Sebastian.
absolutely. To do those testing, to do screening colonoscopy at the age of 50. And I think we just have to get an understanding that this is not for fun. You have a risk. 1 out of 20 patients, or one out of 20 people will have the diagnosis of colorectal cancer during their lifetime. That's a fact. Okay. And early on, we could not only, with a change of your diet, you can lower your risk, but if you are on risk, I think it's important to know if one of your that you also have a higher risk if you are, a little bit obese, if you, smoke, if you maybe drink alcohol, that you say, okay, then you have probably a risk of not 1 out of 20, maybe 1 out of 10 is going to get colorectal cancer. And so with those easy numbers, easy to understand numbers, to really get awareness in those people, in those communities, to get them screened. And also, of course, patients that are not able to speak, for example, English or German properly, to really find a way to get this knowledge to those communities and just say, get your screening. If you're fine, you can go home and you have reduced the risk of colorectal cancer for you personally by far. So I think that's something we just could, repeat again and again to really get a bit deeper understanding are the benefits. And overall, neither colonoscopy nor a blood stool test is really a problem.
I'm a strong believer that you speak German is your mother tongue.
Sure.
And I have to say, thank you. I'm so lucky that that everyone around the world speaks English, because my late dad had this expression that if someone speaks English with a foreign accent, they speak one more language than you do, Jonathan. And my German, I did 1 year of German at school, and my teacher was a chap named Bond, Cyril Bond. And I struggled so hard. So thank you for speaking such beautiful English. But just as you speak a different mother tongue to me, people have different ways of communicating. And I think one of the problems we have as doctors is we tend to use the same narrative for all people, regardless, not taking into account cultural nuances, educational nuances, belief systems. In 1964, there was a very famous biologist, John Haldane, who developed rectal cancer. And he wrote a poem about his experience. And I love the lines. I wish I had the voice of Homer to sing of rectal carcinoma, which kills a lot more chaps, in fact, than were bumped off when Troy was sacked. And
Sure.
Then he ended up diagnosing it by doing his own rectal exam. It was a very low cancer. He could obviously feel it. and he had an abdominoperineal resection, and the final lines were, "So now am I like two-faced Janus, the only god who sees his anus," because with a stoma. We need to find other ways to talk to people, and I
Yeah.
would charge our listeners to think about that when talking to your patients. Don't preach, don't dictate, don't mandate, but give people the facts in a way that is not patronizing, nor it goes above their head. Because you could lose me talking about oncologic immunology. You could lose me intellectually in 30 seconds. So we need to do that. I have to say, I'm afraid that's all we've got time for today, but I have to say, Professor Sebastian Stintzing, thank you so much for your very eloquent, well thought out and complete answers. A real joy speaking to you. Next time I'm in Berlin, I'm going to be a naughty boy and ask you out. Let's share a bottle of wine together and talk about oncology and culture. You're a gent. Thank you, Sebastian.
Well, it was a pleasure. And of course, whenever you're in Berlin, you're very much invited, and we will find a place to eat some German food, which is probably kind of colorectal cancer inducing food if you take it too much from it. But however, it was a real pleasure, and I think it was a great talk and nice questions, and I think it's really relevant to listen to what we talked and giving us a little bit a hint where the area is moving right now. So thank you so much.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.